Okay, students, apologies for missing class this morning or this afternoon. I'm going to try to record this lecture, and I am going to go quickly through this information. If you have any questions about anything, please write down your questions and let's talk about it on Friday. And then you have your first exam on Sunday. It covers the information from week 1, 2, and 3. And so it's Sunday. The exam opens at 5. It's open for 24 hours. When you go in to take your exam, you have 75 minutes to complete your exam. There's 50 questions. There's also the bonus exam. There's 10 questions on that. I think you have 15 minutes to do that. We talked about the bonus exam. It's those questions with the multiple correct answers. You have to get every correct choice selected to get the question right. And if you get the question right, I will give you extra points on your exam. If you get questions wrong, I do not count points at all against you. Okay, so this is just, it is for your benefit and getting a few extra points on your exam, plus giving you practice taking these kind of questions, which will be on the NCLEX. So documentation chapter, I'm going to run through this pretty quickly. It's pretty easy information to understand. So we're going to kind of go through this. Your learning outcomes, I'm not going to explain them further to you as I usually do, so you can read over those. We're just going to kind of zip through right here, zip through this really quick. So wanted to talk about the electronic health record. So there's the electronic health record and there's the electronic medical record. Very similar terminology, but mean very different things. So the electronic medical record is the record of the admission or the doctor's visit that one particular time. So if I'm admitted to the hospital for pneumonia, that admission, if I was there for 5 days, that is one medical record for me. If I went to the doctor's office and had a visit at my primary care, that visit is its own medical record of that visit. So each visit, inpatient, outpatient, has its own medical record for just that visit. And then when you combine all the visits from my outpatient, my clinics, my hospitals, my surgeries, when you combine all those into my file, that's my health record. Okay. And then the computerized order entry, provider order entry, is just a term that you'll hear. It's where a physician can place their orders on their patient into the computer, and those orders will go to the different departments that they need to go to. For instance, if he orders an x-ray on a patient, it will go to the radiology department. It'll print up on their computers, and then they can prepare to get the x-ray done. If the physician orders labs, it'll go to the lab. They'll be notified. They'll come up. They'll draw the patient's blood or whatever the lab is, and so forth and so on. Computerized order entry. And then, some things about the health record or the medical record, either one, is the great thing about it is it's electronic. We could do digital recordings, voice recordings. We can use the different hardware that comes with whatever program we have for documentation, like laptops, tablets, handheld devices, light pens, all kinds of things. The electronic health record allows us to do point of care entry. So what that means is we're at the patient's bedside, we're providing care, and we have a computer right there where we can document the care we had been given. And then, of course, also anything that we document will help us with reimbursement, for insurance and billing purposes. It will protect us as healthcare providers if we do proper documentation and proper care. It is a record. It is our defense of the care we had given and that we were meeting the standards of care. So documentation is very important for us in that aspect, but also if something went wrong in the care we provided, then it's also going to help the patient if they're trying to recover damages, all right? The record can be used for research, especially when like you're gathering all records on patients who were admitted with pneumonia and had this kind of treatment, or if you're looking at all patients who had an indwelling Foley catheter placed, you can look at the technique, the length of time, the level of infection, and all this kind of stuff. So it can be used for research or data, statistical data for the government. The health record can help us establish policies and procedures, regulations, and appropriate standards of care. So the health record has many purposes. Documentation, not just nursing, of course, is a permanent part of the medical record. It's all the care that we've provided to our patient. It can be used to demonstrate professional or legal standards were met. Like I said, that we provided the care we were supposed to provide, and again, it can be used for reimbursement. And so it's very important that we are clear, concise, we are complete with our documentation. We document objectively. We do not put our judgments or biases into our documentation. We do need proper spelling and grammar. However, our computer programs help us with that, and we should record as soon as possible after the event has occurred. So if I did a wound care, it would be great if right as soon as I completed the wound care, I documented right at the patient's bedside. That increases the accuracy and completeness of my documentation in a timely manner. So if I do all these cares on these patients and I go from one room to the next, to the next, to the next, and I don't document, and then at the end of all that time that I've done all those cares, I go finally sit down and document, then my recollection and my thoroughness will not be as accurate as it was if I would have done it right after the event. So documenting at the point of care is great. Do not use abbreviations. So we need to be consistent and standardized across the board, across the country, in how we document and the abbreviations we use. And we are able to do that because there are published lists of what abbreviations to use and what not to use, why it's a problem, what errors occur, and then what is the correct way to then document. So get familiar with this list. It is in week 3 on Moodle for you to look over. Using correct documentation and correct abbreviations it decreases patient errors. So like for this, if we were to use one of these U's as unit, it could be mistaken for a 0. And then maybe the dosage is, instead of saying 5 units, maybe we thought it said 50 of the dosage, and we give the patient way more and we cause patient harm. So that's what we have discovered as causing problems and contributing to patient errors is using incorrect abbreviations. So here's your correct one. So again, this is on Moodle. Please look at it. Be familiar. There's another one I have on here. Of course, I've got to find it. Here, this is also on Moodle. Here is another one that's been published of abbreviations and how they can be misinterpreted and what is the best way to write those things. So please look at that as well. I just opened too many. I've got too many things open. Wow. Anyways, we're going to go over these other forms in a second. So, all right. So back to our lecture. I think, let's see how, so we talked about the do not use abbreviations, so please look at those. Now, a lot of times when you're documenting, you have a standard format for documenting programs that the facilities use to make documentation easier. Like for instance, if we're doing an assessment on a patient's respiratory system, they will have a respiratory tab, and they'll have all the parameters that we're assessing in there, and then we go to that parameter and then we will select the appropriate response. So it's very easy to document that way. But if there's something we need to say about the patient that is not in one of those standard formats where we can just click a one-word response answer, we need to document a narrative. Most places use this SOAP note documentation way of documenting. And I say SOAP note because this was SOAP was the initial, this is the basic format of a narrative note, SOAP. So what does SOAP stand for? S stands for the subjective information, what the patient tells or others tell you. Okay, that's subjective information. And then the objective information are what are the assessment findings or the result of your exam. What are the results of the test, the objective information that can be proven. A stands for assessment. What is the patient's current status? P stands for plan. What are the interventions that you need to do, okay, that are necessary for this patient? The I stands for interventions that the nurse provides. E stands for what the patient outcomes or evaluation of the intervention, or did it work? And then R, so you reevaluate the plan. Does the plan need to stay the same? What are the changes? Most of nurses' documentation is going to be in that standard format where we go to respiratory, we click our responses, we go to cardiac, we click our responses, and only occasionally will we need to do a SOAP note. And we can do that. We can do that on the computer as well. Now, when we do chart, so when we get to the respiratory section and we're clicking the responses that we select, they're going to be charting. It's going to be what's called charting by exceptions. So, in other words, on the respiratory section, you'll be saying normal, within normal limits, okay? Or we're assuming that everything is within normal limits. And what we are actually recording is the things that are not in normal limits. So if I chart by exception, I might say, respiratory-wise, I might say within normal limits except crackles bilaterally in the bases of the lungs, or something like that. I'm charting what the exception is to the norm. So you'll be charting by exception in most facilities. There's things called flow sheets and checklists. These are things where we document things we do routinely, like vital signs. We may do vital signs every 2 minutes. We may do them every 2 hours. We may do them every 12 hours. But we would chart them on a flow sheet so that when we go to look at our vital signs over the period of the patient's stay, it's in one sheet, in one area. We can see the trend from vital sign to vital sign. I's and O's are in flow sheets. Medications are in a flow sheet. Things like that happen on a routine, frequent, regular basis. That's what flow sheets are. Checklists are basically, I have a patient that needs a central line dressing change, and this checklist will walk me through the steps, all the steps I need to do to provide standard evidence-based dressing changes on a central line. Or the checklist will be blood pressure parameters. So this is my patient's blood pressure. These are my patient's heart rates. What shall I do with the medication? So there's those checklists. If your patient's blood pressure is this, check, you do this. Okay, so those are kind of sort of other examples of checklists. A Cardex, you probably won't hear this term anymore. It's an old term, but still the system or what it represents we still use today. So a Cardex is usually a non-permanent part of the patient's record. So remember I said everything about the patient is a permanent part of the record. Well, a Cardex is not, just because the Cardex is basically a to-do list. All the orders are in the chart. All the treatments are in the chart. But the Cardex is my daily to-do list, which doesn't need to be part of the chart. Okay, it's kind of redundant to the information that's in the chart, but for my shift, it is a shortened version. It's a snapshot of my the day that I am going to have with my patient, the things I need to do for my patient. So that's why it's not a permanent part. It's basically just a tool for the people providing care. Now, the medication administration record, of course, is just what it says. It is a record of the medications that we give. So we're able to chart the med we give, what time, what route, and we have this running record of the medications. Barcode medication administration, that's what most of the facilities are moving towards now, where you give the medication in its package, you scan the package, you scan the patient, they both match. The computer will tell us this is the right drug for this patient, you're giving it at the right time, everything is good. Or it will say, oh, this medication is not on this patient's record. Are you sure you want to give this medication? So it could help prevent medication errors. It can also say, oh yes, this is the medication you're supposed to give the patient, but this is the wrong dose. So it is a huge tool in decreasing medication errors. And then also with the documentation, you will want to be familiar with the admission summaries, more importantly, and then the discharge summaries. Well, the admission summaries more importantly, and then also the discharge summaries. So the admission summaries, the physician fills out, and basically it's just a summary of why this patient is being admitted and a summary of their health status, health history, okay? Discharge summary, of course, is done summarizing the patient's stay and what the plans are for discharge and follow-up and things like that. Again, the chart is a legal document. We can use these to protect defend the care that we had given. If a patient sues us and we go to trial, it also the patient can also use it to support their case. All right. So every entry is time-stamped, and because I logged into the computer, it's also going to be signed by me just because I logged in, which is one of the reasons why you never want to share your login with anyone, or you never want to leave your computer without logging out, because whatever is documented in that patient's chart is going to be saved under that user. So you don't want to be the user. You don't want to be the person providing care when you really didn't. Okay, so and then if there was any mistakes to the documentation, there's a correct way to note those errors. For the electronic record, you can delete them and retype the correct answer, but when the record is pulled for review, it will show the error that was deleted. So that's cool and good. If it's a written record and an error was made, then you draw a line through the error, you write error, and then you initial it so that that can be identified. The health record is confidential and private, so that's where HIPAA comes in. So we need to protect that privacy. We need to make sure that charts aren't open on the desk for people who are walking by to see them. Computers aren't left open. Information has to be protected. And then also our discussions with the healthcare team, we have to make sure that we're in privacy so that we're not sharing it with people who are in the elevator with us or walking around the corner or whatever. So This is a federal mandate, a federal law, Health Insurance Portability and Accountability Act, that does list the rules for privacy and confidentiality, what can be shared, how it can be shared, and things like that. And so if we break confidentiality and privacy, or we break the HIPAA protection for our patients, we can be, reprimanded with up to a healthy fine, imprisonment, loss of our job, and so it's a really major thing. All right, handoffs. We're going to talk about these real quick. This is basically giving a report to another healthcare worker. So we're handing off care to another healthcare worker. There's a standardized way in which to do that, and we'll be going over it. So this is our either face-to-face, our recorded, a telephone, or written handoff information about the patient to the next provider. We do that when we change shifts, when the physician changes shifts, when the nurses change shifts. We do that when we transfer a patient from one unit to the other, or if we're just changing nurses during the shift, transferring care during the shift on the same unit. So anyways, but this is a big risk in patient safety because information gets left out, important information, treatments get missed, medications get missed. So this is where a lot of errors occur in patient care. So we try to follow a standardized format, a handoff report that we can fill in or use to guide us in our conversation with the healthcare team. Now, again, I said this is a part of a huge area of patient errors contributing to sentinel events, which brings me to this other document that I have on Moodle. It describes what sentinel events are, but basically it is an event, a patient error, something that happens to the patient that causes death, permanent harm, or severe temporary harm, requiring critical or life-saving interventions, okay? So those are called sentinel events. The government or Joint Commission keeps track of those. Each facility has, most facilities even have their own department, and all they do is track sentinel events of every patient in the facility. And then they have to submit all that documentation to JACO, and that's where they get all their statistics. But look through this article. You can see some of the more common type of sentinel events, the statistics on these sentinel events. So it's pretty interesting. Wrong patient, wrong site, wrong procedure, wrong med, wrong dose, wrong patient, a patient fall, surgery, retention of foreign objects in surgery, so falls, patient suicides, delays in treatment causing sentinel events. So look through these. It's interesting and good for you to be aware of. And then based on those, some of the most common sentinel events, this document on National Patient Safety Goals. So every hospital has to have a procedure in place to protect the patients in all these different incidences. These are the ones that are the most common events for patients. So identifying patients correctly. So we haven't done that, and we've given the wrong patient the wrong med, or we've done done surgery on the wrong patient, or whatever. Okay. Improve staff communication. So this is our handoff report that we're giving all the information that we need to give. Using medicine safely. So giving our how many is it now? 7 rights to medication safety administration. Alarm safety. So this is where the patient is on some sort of monitor, that we set the parameters for the alarms correctly, and we set the alarm volumes correctly, and that therefore that we are alerted when the patient hits an alarm state. Prevention of infection, there are lots of guidelines here for prevention of infection. Identifying patient safety risks, so falls, suicides, things like that. And then prevent mistakes in surgery, wrong body part, retained surgical things. So this would be good to look over. And it would be nice for us to see what our facilities are doing to meet these standards, so they all have something in place. All right, so let's continue here with our lecture. So SBAR is the mnemonic we use for giving report or handoff, and usually this is the style that we do it when we do a nurse-physician interaction. So the nurse is calling the physician, she wants to report something to the physician, and she wants to get the physician's feedback from that. So this is the format in which she will provide information. Okay, so we're going to review what that means, what each of those means. So SBAR stands for Situation, Background, Assessment, and Recommendation. So situation, what is happening at the current time with the patient? Background, what are the circumstances leading up to this situation? Assessment, what does the nurse think the problem is? And recommendation, what should we do to correct the problem? So I've kind of put a couple of examples in here. You can look over these, but SBAR is kind of difficult, kind of like everything in nursing. But once you practice this, it will become second nature to you. So let's look at a few of these. So the situation is the nurse is calling Dr. Thomas. This is Lisa. In ICU at OMH hospital. I'm caring for Mr. Jones in room 5. Mr. Jones has had a change in his heart rhythm. That is the current 2-sentence version of what's going on. Okay. Background. Mr. Jones had hip surgery 2 days ago and has been going in and out of controlled AFib since his surgery with rates in the 90s. Mr. Jones has a history of AFib and was on Coumadin 5 milligrams a day and digoxin 0.2 milligrams a day prior to his hip replacement. He has not had any dig or Coumadin since his surgery. That's the background. Okay. My assessment, Dr. Thomas, is this morning Mr. Jones has gone into uncontrolled AFib with a rate of 120 to 130 range. He is currently asymptomatic and his vitals are stable with a blood pressure of 120/80. He is resting comfortably in his room. These are the things I've assessed. Okay. My recommendation, Dr. Thomas, is I am thinking that a 12-lead EKG should be ordered for Mr. Jones. Also, would you like his digoxin and or his Coumadin to resume? Are there any other tests that you would like me to order? And then blah, 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 what the doctor says. And then I say, I will call you if Mr. Jones converts or becomes symptomatic. Would you like me to call for any other information? Okay, so that's a pretty good example for you. Here's another one. Doctor, hello. This is Jenny from OB at OMH Hospital calling to let you know that Mrs. Winslow has been admitted in early labor. 1-sentence situation. The background, doctor, is that Mrs. Winslow presented to the emergency department around 1600 this evening. She is a 40-year-old Gravida 1 Para 2. She started in labor at 0900 today. She is Rh positive, GBS positive, and rubella immune. Her Hep B status is unknown. Her membranes are intact. Mrs. Winslow has an allergy to penicillin, reaction unknown, and became allergic to penicillin as a child. And this is a typo right here. This should say Gravida 2 Para 1. So apologies there. Oops. Okay, so my assessment, so I'm not going to read that to you. This is what I assessed on the patient. So my recommendation, doctor, is may I enter your labor and delivery order set? Since Jane is GBS positive, what treatment would you like? Would you like any other tests? How would you like me to contact you today? Okay, and then so here's a third example. Please read over this yourself. Okay, so this is SBAR, how we talk to our docs. Now, here is an example of what report sheets would look like. So these report sheets are the sheets that we use to give report to other nurses as we pass the patient either from shift to shift or from unit to unit. Okay, sorry, her demographics. Okay, a brief demographic. The department specific information. So this would be what I would tell in the OB department. This would not be what you would tell in like ICU or something like that. They would have their own department specific patient data. I'd give a brief history, current meds, the orders, and any interdisciplinary orders, and then any other information that would be helpful for taking care of this patient. So those are our report sheets. Now, our verbal and telephone orders. So physicians can, come into the hospital, see the patient, write orders or put them in a computer, and then go about their business. Or they could be at their house or their office and put in orders. Or they could call you on the telephone and say, hey, nurse, I want you to give the patient in room 6 Tylenol, and he could give you a Tylenol order. Or verbal orders, so that's a telephone order. A verbal order is the physician standing there, and he tells me, hey, go ahead and give this patient Tylenol, and then that's what is called a verbal order. Now, when we enter those verbal orders or telephone orders, our documentation must be as followed. We write the order, and then we repeat the order verbatim. So he gives me the order Tylenol, 625 or 650, I'm sorry, 650 milligrams, give oral now. Okay, then I would repeat that back to the physician, and then I would document read back verified, or I would document RBV when I put that into the computer. That means that I read the orders back to the physician to verify that I heard them correctly. If it's a telephone order, or you would say TO for telephone order or VO for verbal order. We would date it and sign it, of course. Okay. Now, the last thing we're going to cover here in this chapter is incident reports. This is documentation, but this is also not part of the patient's chart. An incident report is a report of an unusual or unexpected event, like a patient falls, or falls out of bed, or you gave the wrong medication, or something like that. It's an incident, unexpected or unusual event. Okay, it's documentation of that event. It's not part of the chart. It is for quality improvement, risk management efforts. So it's not punitive. It's to have a record of what happened, and then we look for trends. Is there a trend that's causing all these medication errors? Is there something that's causing all these patients to fall? Things like that. And then after we have identified a problem, then we make a plan to address that problem. Why are these medications being given incorrectly all the time? Is there a theme or something that sets the nurse up for making this error? And let's eliminate that problem and then eliminate those errors, okay? So it's a risk management tool. It is not part of the patient record. Nor do you make any documentation in the patient's record that an incident report was written. Now, if something goes wrong with the patient, you have to document what went wrong with the patient in the chart. But you do not put the incident report that you will also be filling out into the chart, and you do not write in the chart an incident report was generated. You just put the basic facts of what happened in the patient's chart. Okay, so if that was confusing, let me know. Now, let's move on to chapter 20. It is a lengthy chapter, and I'm going to hit the highlights. Now, these are your learning outcomes. Again, I'm not going to explain these. Please read over them. The first part of receiving a patient is conducting a patient interview. It's really silly to break it down like that, but there are clear steps in this admission process for your patient, and a lot of your assessment is going to be your interview, talking to the patient, getting information about their current history and their past history. So, excuse me. So we do this interview and we gather information from our patient. We find out their demographics, allergies and vaccinations, what medications they're on, what is their medical history, and what is their surgical history. We also, and family history. Family history is supposed to be in here too. I apologize, that's not listed. And then we also ask we do a social interview, a living activities of daily living interview, educational questionnaire, psychological evaluation, nutritional evaluation, a functional evaluation, a fall risk, and a suicide risk evaluation. And so that's why, oops, sorry, that's why admissions can get lengthy because, well, how do you make that go away? Okay, so let's move on. Also with this admission, we're going to be doing a review of systems, and we review the system, each one of these systems, with the patient. We ask the patient, do you have problems with any one of these systems? That's a review of systems, different from the physical assessment where we are actually, so this is subjective information we're receiving from the patient. Okay, this is about current and past status. So if my patient's being admitted for pneumonia and I do a review of systems, I'm going to ask them, do you have any problems with your skin? They might tell me I have eczema, or they may have psoriasis. Okay, or they may say, well, since I've been sick, I've been laying in bed and I'm starting to get sores on my butt. Okay, so that's a review of those systems. Now, when I do my physical assessment, I am going to see or objectively find those skin problems. Okay, so review of systems is a subjective interview with the patient, and then your physical assessment is where you're actually gathering, you're actually physically performing an assessment and obtaining objective data. All right. So what do we do when we start our physical assessment is we got to prepare the room and prepare the patient. So we've got to gather all of our equipment. We've got to try to close the curtain or close the door to give the patient privacy. We need adequate lighting, of course, to see what we're doing. And then we need to make sure our patient is comfortable, that they're warm, and that they're in a position where we can perform the exam. Okay, so gathering equipment is something that we like to stress because you go into a room and you do your assessment on your patient. Maybe you have them laying in the lithotomy position because you're doing a pelvic exam. So you've got them in the stirrups and they're draped and their bottom is hanging out to the world, and you say, oh, I forgot my speculums to do this exam. Please just wait a moment. I'll be right back. Like, that's not cool to leave someone sitting like that. So gather all your equipment and try to make sure you have it in the room and that your equipment is warm and clean and all that kind of stuff. Here are some ideas of some equipment depending on what kind of assessment that you're doing. So we talked about preparing our patients, identifying our patients, privacy, making sure the patients are comfortable, and then washing our hands before we touch our patient. Okay, positioning. So depending on what kind of exam we do, we want to position the patient in the most optimal way for our assessment, for our ability to perform the assessment. But we need to make sure that our patient is comfortable. So if we wanted to lay our patient flat on the bed to assess their abdomen and stuff, because of comorbidity conditions or the fact that this person is obese, laying flat on their back is very uncomfortable for them. So we need to try to accommodate the patient as best we can. We need to have a general idea of their age and level of cognitive ability, so that they're understanding what we're doing. Okay. Limit time spent in changing positions. So if I listen to the heart and the lungs, and then I need to set the patient up or roll the patient over to listen to the lungs on the back, I do that. But then when I do that, do my kidney assessment, and if I need some sort of sacral assessment or spine assessment, I do it all then when I've had the patient roll over. So you may not be doing your assessment in a chronological order as far as systems are concerned, but as far as the patient is concerned, their positioning, all right? And then just making sure you're only exposing what you need to expose to protect the patient's privacy. Now, I'm not going to go through each one of these. You can go through these, but you can look at all these different positions and how, what part of the anatomy or what part of the assessment is best to be doing. And then, of course, why sometimes it might be hard to be in that position. Okay, so here's your supine position where you have access to the whole front of the body. And it's not, the body's not sitting up and crunched and doubled over or anything like that. Dorsal recumbent in Fowler's position, so you can see, you know, what you have access to assessing here. The lithotomy position or the prone position, here it will tell you the good assessment pieces with those positions, and here are those positions for you to see. Sims position, the chest position, here are the things for that. And then here was what those positions look like. Assessment techniques. So we're going to run through this really quick as well, because we're really going to be practicing this in lab class. So our techniques are inspection, palpation, percussion, and auscultation. When we perform these, we don't need to wear gloves or personal protective equipment unless we need to. So what I'm saying is you can do an assessment on a patient and not have to wear gloves, or there may be, you know, when you're assessing the patient, there may be body fluids involved. Those body fluids may be infectious, so we might need personal protective equipment. So just depending, okay? So inspection is visualization, observation, looking at features, the patient's, their physical appearance, as far as cleanliness, their skin, their hair, their gait. Oops, sorry. Sorry. Anyways, you know, what we see in our patients, we can observe mucous membranes. Do they look pink? Do they look moist? And then also smells. We can scrutinize smells that will help with our documentation. We look at, when we look at one side of the body, we look at the corresponding other side, so right and left. So that's our inspection. Also, when we're inspecting, like when we're doing our respiratory, we have to observe the lungs. We have to observe the chest. It's not just using the stethoscope to listen to breath sounds. We have to observe breath excursion, lung excursion, look for traumatic injuries, things like that. I look at the skin on the chest, especially women with pendulous breasts, you know, things like that. So inspection is looking at every body system as we go through our assessment. Palpation uses touch to assess position and status of a body organ, to assess skin temperature, texture, tenderness, things like that. So we use our fingertips, we use our palms, we use palpation, pressing, to feel what's going on. Now, when we feel, some of the things we can feel, of course, is our organ location, the size, if there's any deformities in the organ. We can be feeling rigidity or crepitus, cracking or rubbing sensation when we're pressing. We can, when we're pressing, we can cause the patient to do guarding, where they're positioning themselves because of a pain. So they have pain in their belly, so they're covering their belly. Rebound tenderness is when we palpate the belly and we remove our hand and then it hurts. That's rebound tenderness. So we're feeling all kinds of things. Okay. Here is light palpation, where we're just basically the skin level. Deep palpation is we're trying to get to the organs underneath. Okay. Percussion is when we tap over a part of a patient's body. I am not skilled at percussion, but it just sounds different in different densities of different organs, different fluid volumes, and things like that. But the one time I do use percussion is when I'm percussing here. So along the lower back, when I'm percussing here, I'm looking for tenderness, which would indicate a kidney problem. Okay. So that's where I use percussion. But percussion for for hearing the different densities of different organs or different body spaces or different fluid volume spaces, like I'm not really able to do that, except for like if I'm palpating someone's abdomen. I'm not really percussing, but if their abdomen is full of gas, then it's it's going to be buoyant. I can tell that. But other things like feeling organs, like feeling livers and things like that, I'm not skillful at. Auscultation is using our stethoscope to listen to sounds within an abdominal cavity. The ones that you will be most familiar with, of course, are the heart, blood vessels. So we can auscultate over blood vessels and hear sounds that probably we don't want to be hearing. Lung sounds. Lungs always have sounds just like the heart does, and then they always have abnormal sounds, the heart and lungs. So they have normal and abnormal sounds. Over the abdominal cavity, they have normal sounds that we want to be hearing, or abnormal sounds as well. So, which we will need to identify. Most stethoscopes have two different heads. Well, one head with two different sides. There's the diaphragm and the bell, and you just twist it and you activate the diaphragm listening portion, or you twist it again and you activate the bell portion. So the diaphragm is the flat piece. That's the one where you listen for breath sounds, bowel sounds, and heart sounds. Okay. The bell part is that concave, smaller looking side. It's used for assessing low-pitched sounds like distant heart sounds or extra heart sounds or heart murmurs, things like that. So, and sometimes we use the bell to listen to babies' bowel sounds, because they can be pretty quiet just normally. Anyways, problems when we're doing that is we can get artifact. So we need to practice holding the stethoscope and listening, artifact or interference. Like if we're rubbing the tubing on our stethoscope, or if we're rubbing the head of our stethoscope, or anything like that, then it's going to cause interference or different sounds. And then, of course, over fabric, we really don't want to ever be listening over fabric. If we can avoid it, right onto the skin is best. All right. The physical exam. So this is basically walking you through how we're doing this physical exam. So inspection is first. We're looking at the skin. We're talking to our patient. We're looking at the skin. We're palpating. the skin, and we're doing our skin assessment first. We can be doing our skin assessment, our hair assessment, our nail assessment, just when we're doing our interview, just by observation or inspection, seeing what's going on. And then a lot of times, I don't like dig in a person's hair, feel their scalp, unless it's indicated for their condition. I will do a general visual assessment of their hair and scalp. I will do a general visual inspection of their nails, but I will not be doing some sort of thorough fingernail, toenail exam unless there is a reason, a more pertinent reason to look at that. But just general observation is what I'm doing. Capillary refill is lumped in here too, although capillary refill is telling us about circulation. So it's when we apply pressure to the nail bed of the finger or the toe, we apply pressure for about a second or so, and then we release it. And when we have the pressure applied, then the area should be white or what we call blanched. That is, we have squished all the blood out of those capillaries, okay? And so it's white. When we release it, the blood is able to flow back into that area we applied the pressure, and it should become pink again or skin colored again, and that should take less than 3 seconds. That is capillary refill. Okay, if it takes longer than 3 seconds, then the patient is suffering from some sort of circulatory problem. It could have a respiratory component. It could have a heart component. It is associated with hypoxia, that's lack of oxygen in the tissues. It may be a result of anemia, not enough blood, or some combination of other stuff, okay? But it's telling us about our circulation. When we're doing our general inspection of the hair, nails, and stuff like that, we're looking at the eyes and the face and the ears and all those kind of things. I am not doing really thorough exams. I'm not getting an ophthalmoscope to look in the eyeballs. I'm not getting an otoscope to look in the ears or nose, unless that is pertinent to my exam, which a general hospital patient it is not. What I do typically do, not on OB patients, but on sick patients, I will look at their pupils. And so we are going to practice this as part of our standard assessment, where we're going to look at the pupils. We shine a light in the eyeballs. So this is just a guesstimate. You're not going to measure their pupils with a measuring device, but you're going to have to try to learn what the sizes look like so that you can tell what their normal pupil size is. And then we will be using the pen light to assess for pupil reflex. So we shine the light in their eyes and we expect that pupil to constrict. We do accommodation to see that the eyes focus on objects that are brought near to the face and that we have the divergent pupils and the constriction of the pupils. That tells us accommodation. We don't need to do accommodation if our patient's pupillary reaction was normal. But if our patient's pupillary reaction was not normal, if it was sluggish or non-existent, then we need to do the accommodation test. But when we document that, if it was all normal, we're saying pupils were equal round reactive to light with accommodation. Okay, but if we don't do the accommodation, then we don't put the A on there. And remember, you don't need to do the accommodation unless their pupillary reactivity was abnormal. Now, equilibrium, I don't make my patients stand up and do this Romberg test to test their equilibrium. However, if they were having an inner ear problem, a balance problem, if they were saying that they were having vertigo or dizziness or the room is spinning, yes, definitely, I would be doing a Romberg test. But on my normal assessment, no. On my normal assessment, I don't usually do a lymph node exam. However, if my patient is there for infection or to rule out infection or something like that, then I will do a lymph node assessment that is a visualization and palpation inspection. Okay, so usually you begin at the neck. You have the patient raise their chin just a little bit slightly and turn their head to one side, and you palpate. Usually you don't feel lymph nodes, but if they're swollen or if there's increased lymph node drainage, you may feel, you may palpate the lymph nodes. So bilaterally, they should be symmetrical. And a non-tender. And so if you're feeling them, you're going to note the size, what they seem to feel like, their shape, where they're located, and if you feel any nodules or lumps or bumps or anything, you're going to say whether it's soft or not and non-tender, and then document if there was any abnormalities to your assessment. Okay, here are so you can palpate with your fingertips down around the ear. So like however you find the order in which you do them that best meets your personality. So I usually, if I'm doing it, I just usually palpate around the ear, and I palpate back here behind the ear. Okay, then I start palpating on this posterior lateral side of the neck, on either side of this neck muscle, and then under the chin, and then down along that top of their shoulder area around their here. So if I did a lymph node assessment, that would be my route, or that would be my order in which I do it. So when I assess the neck, of course, I'm basically just looking at it. I may palpate it if it's significant to my patient's diagnosis, but usually I just do an inspection, and if I see something, I'll palpate. I don't usually auscultate. When we auscultate, we're auscultating for a brutus in the carotids. We could palpate our jugular veins for distension. Otherwise, I don't really do a neck palpation, just a visual observation. And if something is abnormal, I might palpate. I auscultate the carotid arteries. I'm looking for what we call a brute, which is an abnormal swishing sound. So you should not be hearing any swishing or blood flow in the carotid artery. If you do, it's called a brute, and it is significant and needs to be evaluated. The thyroid gland, again, I don't usually palpate, just a visual inspection if it's really significant with my patient's diagnosis, and then I may palpate if I see something or if it is significant. Trachea, same thing. I'm not really palpating when they swallow or any of those kind of things. It's just a visualization. If I need to do anything further, I will. Now, respiratory assessment. Probably this is one of the things you'll always assess on every patient, where we're listening to breath sounds. So we listen on the front, which is anterior. We also listen on the back. And then we also visualize and palpate the front and the back. So when a patient's breathing, we want to watch and see that expansion, and see that it's symmetrical, that both sides are expanding the same. We want to look to see if they're using any accessory muscles, like the muscles between their ribs, below their sternum, below their ribs, to help them breathe. And then, of course, we're doing a skin assessment of their chest and back when we're doing all of this. And then we listen. We palpate for any pain, or, God forbid we feel any fractures or anything like that. So we need to kind of palpate and visualize and watch them breathe. And then, of course, we need to listen. We should be able to hear breath sounds in and out. And then, of course, the normal respiratory rate, 12 to 20 beats. And then we need to document any abnormalities. So if you go to auscultation.com, I think I mentioned this to you, you can listen to some of the abnormal breath sounds that we listen for. and those abnormal breath sounds will probably tell you what's going on with the patient, okay? Um, so, one of the things that we would see with a patient who has uh, a respiratory problem or respiratory disease is we might see a chest diameter that looks the same all the way around. In other words, they look like their chest is a barrel. Instead of their anterior posterior diameter being smaller than their transverse diameter, they're the same. And then we may see that person using neck muscles to breathe. We may see them leaning forward with their hands up on um, the table in this like tripod position, or on their knees, or leaning forward, propping themselves up with their hands to help breathe. This will give us an indication that they have some severe lung disease or some severe problems breathing, okay? Whether it's chronic or not. We want to ask the patient if they're having any problems breathing, if they're short of breath, if they're having difficulty breathing. We want to observe to see if they're guarding or splinting their chest to indicate some sort of problem that we can assess for. And then also related to the respiratory system is if a person is not able to breathe and get oxygen in, they're going to have low oxygen to the brain. That's called cerebral hypoxia. And then we will see that in their mental status. So they might be lethargic, drowsy, they might be restless or anxious, they might be irritable, they might be disoriented, and that would clue us in their consciousness. They may not have the ability to stay conscious, and that will tell us a little bit about how much oxygen is they're getting or not getting to their brain. Okay, so palpation, again, I said we're looking for size, shape, and movement, and pain. Are we causing any pain with palpation? Are we feeling any lumps or anything abnormal? Okay. Tactile fremitus, I don't ever really assess for, but that's when we can palpate a vibration in the chest when the person talks. So you can practice this on one another if you want to. And see if you can feel the tactile fremitus, okay? Chest excursion again, so we're visualizing whether or not the patient's expanding symmetrically when they breathe in and out. And then we auscultate front to back, left to right. So you do the front, and I go from left to right, side to side sequence, going down the lungs on the front and going down the lungs on the back. Okay, so I move from respiratory to cardiac. So this is where we're going to inspect, palpate, and auscultate our heart sounds. So I don't usually like inspect and palpate a heart, but you know, you can practice doing this technique. I am usually just auscultating the heart. So there are landmarks that you can use for your palpation, and this would be cool to practice finding the second intercostal space, so between the second and third rib, finding the second area to palpate is the pulmonic region between the second and third intercostal space, the tricuspid area between the fourth and fifth. The mitral area is between the fifth intercostal space on the left side of the heart, or I'm sorry, the left side of the sternum, and then you can palpate the apical point of maximal impulse of the apical heart, point of maximal impulse, and that's at the fifth intercostal space, mid-clavicular line. You should be able to palpate a pulse there. But anyways, you can do all your inspections and palpations. Again, I don't really do it. I just do the auscultation. I'm listening in my different regions. I'm of the heart for my S1, S2, the normal heart sound, the lub-dub sound. And then if I hear any other heart sounds, those are either S3 or S4 sounds. They're the extra sounds that you hear along with the lub-dub, and those need to be noted. They're a murmur of some sort, and they could be benign or they could need intervention. So there's those. And when you do when you auscultate the heart, you usually do it for 1 full minute. That's if you're getting an apical pulse. And usually when we get our pulses, we do the radial pulses, but if you need to do an apical pulse because you've palpated an irregular heartbeat in the radial artery, then you will need to listen to an apical pulse. But you'll also just need to listen, not necessarily counting a pulse, but just listening, so you can identify the S1, S2, and identify if there's any other heartbeat sounds or any other murmurs, and then you can identify if there's a dysrhythmia or an irregular heart rate, okay? With patients who do have heart problems, I do feel that you need to palpate for a pulse deficit. So that means you're listening to the apical heart at the same time as you're palpating the radial artery. And if you detect a pulse deficit, it is because you heard the heartbeat, but you did not palpate a pulse with that heartbeat. That is a pulse deficit. Okay. Auscultating for, if you do hear murmurs, they're going to grade those murmurs in intensity, grade 1 through 6. And this is beyond the scope of my practice. But if you are a super wazoo cardiac nurse, then this will be right up your alley. Now, part of the cardiovascular assessment is a peripheral vascular assessment. So, we will palpate the radial arteries bilaterally, and we will palpate the pedal pulse bilaterally. Now, depending on the patient's, if the patient has a peripheral vascular problem, we may be palpating their posterior tibial as well. But we're just assessing for, we're just assessing for blood flow in the extremities when we're doing our peripheral vascular assessment, okay? When we palpate our pulses, we will be documenting the strength of those pulses, 1 being, or 0 being no pulse, but your normal pulse is being a +2. So most of your pulses will be +2. However, abnormalities would be +1, +3, or +4. Here are your sites for your peripheral assessments. I don't typically palpate a carotid artery in my general assessment. However, if I would use that as a site for an emergency assessment, or if my patient had some sort of problem. But otherwise, that's just an emergent assessment, along with the femoral pulse emergent assessment. However, on newborns, we do generally palpate femoral pulses. This is basically our peripheral pulse in newborns. In adults, we do the pedal pulse here, but in newborns, we do this femoral pulse, and we do a brachial pulse in newborns. I don't typically check my adult patients' radial pulse. I just do the radial pulse. I don't even do the ulnar because I just do the radial. And then the popliteal and posterior tibial are not typical pulses that I'll check for my peripheral vascular assessment unless there was some sort of circulatory peripheral problem in these areas. But the dorsalis pedis, or the pedal pulse bilaterally, is my standard. So my radials and my pedal pulses. I don't typically auscultate for brutes unless this is a problem for my patient. Remember, auscultating for brutes is you can auscultate the carotid, but you can also auscultate the abdominal artery for the presence of a bruit. If your pulses are so faint that you can't feel them, then we may need to use a little Doppler to locate those pulses. And there are some patients that you would say, well, I can't palpate it, but their toes are warm and pink, and they have feeling, good sensation. That's great. But if your patient has swelling, they have poor circulation, their toes are going to be cool, clammy, maybe even almost whitish looking. So you can't say that you don't have circulation there. But your circulation is really inhibited. So we do need to get the Doppler out to verify those. So when we assess for venous and arterial insufficiency, so we will be seeing that with skin characteristics. So is there any swelling or redness? Or do we see any protruding, like superficial varicose type veins? Is there any edema? This will give us signs of venous insufficiency. Okay. Arterial insufficiency, these are what we're looking for. You might see pain. If we're not having arterial blood flow or oxygenated blood flow, those tissues are going to start getting ischemic and we're going to feel pain. They're going to be pale. So there'll be pallor present. We will not feel pulse, or they will be pulseless. They may even have numbing or tingling in that area, or they may even have a paralysis in that area. We will assess our capillary refill. And then, of course, these are other indicators. The big one here being ulcers. Lack of hair growth is not a very good, reliable indicator. Brittle, thin skin would be a reliable indicator. And then ulcers would be a reliable indicator for arterial insufficiency. Okay. And then this should have been on your study guide, what phlebitis is, inflammation of a vein. And then when we're assessing our peripheral circulation, part of that assessment is to decide whether or not we might have a clot in the lower extremities. I hate even putting this in my slide because you've probably never heard this before, Homan sign. But we don't do Homan sign anymore. But the reason why I still put it in my slide is because I need to tell you we don't do Homan sign anymore. And that you may find nurses who still do Homan sign, and they may suggest to you, you should be doing Homan sign, and you need to say, no, I'm sorry. Evidence-based practice says Homan sign is contraindicated. And the reason why is because it, one, is unreliable. It can give you a false positive. In other words, they can have a positive Homan sign but not have a blood clot. Or if there was a blood clot and you did a Homan sign, you could dislodge that clot and now they have a pulmonary embolus. Okay? So, what a Homan sign is you dorsiflex the toes back toward the knee quickly, if flexing the toes back towards the knee. That is a Homan sign. If they had a positive Homan sign, when they dorsiflex those toes back towards the knee, they would have pain in their calf. Which is ridiculous because I have pain in my calf when I do that because I'm not flexible. So that's why it's unreliable and tends to give a false positive. So we do not massage reddened areas that we suspect have a DVT, but our assessment is we do palpate the calf. If we palpate the calf and we find warmth, swelling, feel nodules, or cause pain with our palpation, and then we see reddened area, then we can suspect a DVT and we would have an ultrasound done. But we don't palpate we don't massage that area. We do a musculoskeletal assessment. If my patient is a patient who has limited range of motion, has poor mobility, is a fall risk, has gait problems or mentation problems where they're dizzy and stuff like that, I might do a more thorough musculoskeletal assessment where I am assessing their range of motion. I am assessing their strength by having them. This is also a neuromuscular assessment. Is I have them grab my fingers and squeeze. I hold my fingers up, palms facing me, and I have the patient try to pull my hands, and then I try to push the patient's hands. I do the same thing on their feet. That's one way of assessing muscular strength on a patient who is bedridden or bed rest at least. And then doing range of motion with all the major joints: wrists, elbows, shoulders, hips, knees, ankles. You can do the range of motion just by bending, flexing, and extending those joints to see what their mobility is and if there's any pain with that. But if I'm able to observe my patient moving around and walking, then that's great as well. Just putting this on here for you to differentiate between the different abnormal curvatures of the spine, A being lordosis, B being kyphosis, and C being scoliosis. And you may see these deformities in a patient's spine. This would be part of your musculoskeletal documentation. Inspection, if I'm seeing any abnormalities in joints, swollen joints, things like that. Palpation, if I'm palpating for any, bruises or weird things or cracking or crepitus or fractures or things like that. Otherwise, I just do a visual inspection of my patients. So we've talked about range of motion. Deep tendon reflexes, this may be something that, this is a musculoskeletal and a neuro exam, is deep tendon reflexes and clonus. I do these routinely on OB patients, but on your standard med-surg patient, you might not be doing deep tendon reflexes. But anyways, it's when you use the little reflex hammer, you palpate the tendon, and I always go for the knee. I'm not very skillful with the other tendon reflex areas, but I always go for the knee. You use the reflex hammer, you palpate for the tendon, and then you tap the tendon, and you should get a reflex. We're looking at their normal reflexes. They're not too fast and they're not too slow. They're not too brisk or they're not too sluggish. Then we check for clonus, which is very similar to a Homan's test, but not as intense, where we dorsiflex the toe, the foot, flex the toes towards the knee. We just do that softly. We're looking for spastic beats in the foot when we do that. That's called clonus, or repetitive vibratory contraction of the muscle. Okay. Anyways, that is also a neuro test for your patient's seizure threshold. Anyways, a neurological assessment. I don't normally typically do this full neurological assessment on my patients unless their diagnosis is indicative of a problem here. So just differentiating between the central nervous system, which is the brain and the spinal cord, the peripheral nervous system, which is the spinal nerves, and then, there's the autonomic and parasympathetic and sympathetic nervous systems. But here is just a summary of the functions of the different lobes of the brain. So depending on the person's, visual problems, then that would be associated with the occipital lobe. Let's see, brainstem is the critical processes, autonomic processes like blood pressure, breathing, heartbeat, so if you have a problem with your brainstem, it's going to affect these other areas. Not that if you have a person with a blood pressure problem, they have a pressure problem with their brainstem. It could be unrelated to their brainstem. It could be related to the fact that they've drank and smoked and ate fatty foods all their life. I don't know. But if they had an injury to their brainstem, it's going to also affect these areas. So that was kind of rambling. Here are your cranial nerves, and so the cranial nerve 1 is the olfactory nerve. That has to do with a sense of smell. So I hope this is a review for you. This should just be a review for you. But here is the nerves listed 1 through 12, and then here are a couple of sayings to help you try to remember the names of each one of those nerves. You can come up with your own, but here's a couple of them for you. The sensory nervous assessment is basically the patient's ability to sense pain, temperature, vibration, touch, and the position of what's touching them, or where something's touching them, or the position of their body. Okay, we can assess that on our patients by touching their hand lightly and seeing if they can feel that. If they have a peripheral vascular sensory problem, they won't feel that. So how much, so a light touch leading up to a more firmer touch, how much firmer do you have to be for that patient to feel that? Okay. And then, then you can touch a part of their body, and like maybe their toe or their leg, and see if they can identify where you're touching them. I use this a lot when I'm doing my dermatones with my patients who have epidurals. So they don't have a nerve dysfunction per se, or an injury to their spinal cord or brain, or to their peripheral nervous system. They don't have an injury, but we have given them a medication that causes loss of sensation. So I use dermatones in detecting where that medication was given, and identifying the parts of the body that would be numb. Those are called dermatones. So as we see, for example, if numbness exists in the index and middle fingers of either hand, or bilaterally, so it could be on one side or both sides, a lesion or a spinal cord injury to C7 or C8 is where your problem is, based on these symptoms in the finger. Okay, so that's how you can decide where the injury is. Now, when I do dermatones, I'm basically looking at these T2 through T12 here, and we're injecting the patient's epidural in their spinal cord, okay, or in their epidural space of the spinal cord, and then they get numb. And that numbness, let's just say that numbness starts at T8. Well, if you can see from this picture, the numbness starts at T8 and goes all the way down their leg. Okay, so if they're at T8, then they're pretty close to their diaphragm, right? So I want to watch this patient for breathing problems. If their epidural was up here at T7 or above, I'm definitely going to have breathing issues, because these are the nerves that innervate the diaphragm, the lungs, the intercostal muscles, those kind of things. So this is a huge problem. I want my epidural, depending, to be between T8 and T10. In other words, I don't want it going higher. Okay, so what I do is I take a cold alcohol wipe, or the scratchy side of the paper of the alcohol, and I rub it on the patient's skin here at T7. And I say, can you feel that? Yes. What does it feel like? Cold. Okay. Then I rub it down here at the T8 level, and they say, yeah, I can kind of feel that. And I said, does it feel cold? And they say, I can't tell. And then I'll go here at T9 and say, can you feel this? And they say, no, I don't feel anything at all. So their epidural is at the level of T9 and partially at T8. So that's how those things work. Now, when we are looking for coordination, which is something I don't typically do on my patients, even all my med-surg patients. But if I had a stroke patient or a patient with a cerebral vascular accident, a spinal cord accident, I might do a gross motor and a fine motor skill assessment. But on my typical patients, I will not. Mental status is something that we kind of sort of assess on every single patient. We, of course, obtain a baseline of the patient's mental status, and then we evaluate the patient throughout their stay. Like, not so much their intellect, but their behavior, their language. We might be assessing memory skills depending on what kind of injury they had. So we could do some really thorough mental status assessments on a person that had a brain injury, or just on our standards assessment. What's their behavior, what's their level of consciousness, what's their affect. Well, that's kind of like a psychological, but anyways, their mental status also, one of the big things is we check for orientation. Do you know who you are, where you're at, what time it is? And you can ask situation, but if the patient responds appropriately to all four, we say they're alert and oriented times 4, or AO times 4. So person, do you know who you are? And if you go in and say, good morning, Mr. Jones, how are you? If they say, I'm fine, that doesn't mean they know who they are. Okay? They're just responding to your question. Not necessarily that you're calling them the right name. So if you have a person that you are questioning their orientation, you ask them, do you know who you are? Or what is your name? Where are you at today? Do you know what time it is? I hate this one because 99% of the time I have very little knowledge myself of what time it is or even what day it is. But I know, I know what month it is and I know what year it is. So I will ask, what's the month and what's the year? And do you know what's going on? Do you know why you're here? So those are those things. Now, if we have a patient with specific memory problems, we will do a 3-word recall, 3-word or number recall. We will tell them 3 words or numbers, and then we will ask them how they feel. Are they having any pain? Or something like that. And then we will be like, what were those 3 words I just told you a few minutes ago? So anyways, that's a test for short term. And then, of course, long-term memory, we can, ask them about things that happened in the past. We might need to do a cognitive abilities test, but on your standard patient, no. This is more of a rehab, maybe. We have a patient who has a dysfunction. They have a complex health problem where they're going to need to be doing some home cares. Do they have the ability to understand and take care of themselves? Okay. We might need to do an abstract thinking and association test, but not on your typical patient. This is normally in your brain injury patients in that unit if you work there. A Glasgow Coma Scale is a scale that you'll use on a patient to define their level of consciousness if they weren't able to so much respond to you. So it's a scale that's divided into 3 areas: eye-opening, verbal response, or motor response. Each area is scored separately based on the patient's response. The 3 numbers are added together, and then that total reflects their mental status, whether or not they're a comatose patient or whether or not they're a responsive patient. And I have it right here. I was hoping I did. So eye opening. Do they open their eyes spontaneously when you walk in the room or say their name? Do they open their eyes to the verbal command, open your eyes? Do they only open their eyes if you elicit pain in them? Or do they just never open their eyes no matter what? And then, of course, there's the questions on the verbal, and then there's a question on the motor. You give them these scores. And then if you remember from this previous slide, a fully alert, normally responsive patient has a score of 15, so the total possible score is 15. A score of less than 7 reflects a patient who is comatose. So if they score anywhere between 7 and 15, they have some sort of state of arousal deficiency, not comatose, but they're having a level of consciousness deficiency. We will assess their emotional status. It's part of our documentation to assess and document their emotional status. We do an abdominal assessment, and our abdominal assessment involves inspection. So we're looking at the belly, followed by auscultation, and then we can do the palpation and percussion, because usually you inspect, you feel, you listen. You can do inspect, feel, listen anytime you want, or in any order you want, basically, except on the stomach, where auscultation, inspection, and then auscultation before palpation. Because if you palpate or percuss the abdomen, you might change the character of the bowel sounds, which would be not an accurate assessment of their true bowel sound function. So we listen to their bowel sounds in the 4 quadrants. Here they are: right upper, left upper, right lower, left lower. And you document, like if you said absent bowel sounds in the right lower quadrant, you would document absent BS bowel sounds RLQ, right lower quadrant. Okay. With the abdominal inspection, we would like the patient laying flat on their back if possible. However, depending on their comorbidities, you may not be able to do that. We're looking for, we're inspecting for, funny things in the skin, all these things. We're palpating for, and then we're listening. Then we're palpating for masses, lumps, nodules, bruises, pain, any abnormal structure. You would look and assess for those things. When we're palpating the belly, we're also wanting to palpate the bladder area as well, even though we're doing the abdominal inspection, and the bladder is the genitourinary system. This is one of those things where we do things kind of chronologically. We palpate the bladder at the same time we do the bowels, or belly, abdomen. And then we auscultate normal peristalsis, the movement of the intestines to pass contents. That's normal peristalsis. We should hear those sounds within 30 seconds. If we do not hear those sounds, it's abnormal, absence of bowel sounds. Then we need to listen in each quadrant for 5 minutes. And so that's 20 minutes of my time, which in the real world you will not see this happening. But on a test question, this is the correct answer. So absent bowel sounds is you're not hearing any. Hypoactive bowel sounds, which is, they're not, they don't, it's just going to take practice to know what's hypoactive and what's normal. Hyperactive bowel sounds, borborygmy. Anyways, those are basically bowel sounds you can hear without a stethoscope. But anyways, you can also auscultate the abdominal aorta and listening for brutes, which is abnormal if they're present. Then we can palpate in each quadrant after we've listened, looking for tenderness, rebound tenderness, rigidity, guarding, things like that. We can, when we're palpating, we're also not just palpating for pain or lumps or bumps. We can be palpating and noticing a fluid accumulation in the peritoneal cavity, which is called ascites. We can palpate distended bowels, distended bladder. And then lastly, the female genitalia and the male genitalia is not going to be, I don't even have any slides on this part. It would be part of your assessment. Basically just a visual assessment if needed, but for specific problems in these areas, yes, we will do a more thorough evaluation, and that's described in the book. But your normal head-to-toe physical assessment, there is really no there's really no assessment we're going to do besides basically visualization. And then if you found an abnormality, move on. However, if your patient has indwelling catheter, urinary catheter, then we do need to do an inspection of their external genitalia, and also we need to do cleaning care on the external genitalia and the catheter every shift and more often if needed. So that's all to this lecture. Please, again, let me know if you have any specific questions.